Good afternoon. Thank you for joining us for our panel discussion on industry perspectives. My name is Tony Cobb, Director with Westboro Partners. I'm joined by two distinguished panel members, Eric Hammelman, Vice President of Avalere Health, and John Kelliher, Senior Managing Director of Marwood Group. So I will start things off with a few questions for Eric and John, and then we're going to open it up to the floor for you to ask them your own specific questions as well. So start things off, John. This time last year, we were awaiting a Supreme Court decision on the Affordable Care Act. We had a presidential election, which may have put ACA in flux. But this year, it seems like it's full speed ahead. Can you just share with us, from your perspective, policy perspective, kind of the current state of the ACA and the Health Information Exchange, and some of the current key milestones as well?
Yeah, it really is amazing, because I did speak at this very conference last year when we did have all those dangers, and I do think they are dangerous, because I think it's always important to remember and to back up and just kind of stay focused on the macro effect of the Affordable Care Act, right? It is a significant increase in healthcare spending, right? So what the act did and what has now survived the Supreme Court and survived the presidential election is to add a couple of $100 billion per year of new spending on this coverage expansion, right? You're getting 10 million people going into Medicaid, you're getting about 10 million people going into the exchanges, and even with the Supreme Court decision, you only lost a couple million with regard to the states having the ability to sort of opt in or opt out of Medicaid expansion, and you actually picked up a couple of million extra in the exchanges. Half of the money that is going into this coverage expansion is new money. Only half of the pay-fors were shifting from Medicare into the new coverage expansion. The other half, about $100 billion per year, is coming from the tax increases that were in the ACA. So by and large, the healthcare sector as a whole has this new money to a degree sort of landing on it starting January 1 of 2014. And we do expect it to get up and running on time. Don't really buy into sort of 2 days ago, front page of the Wall Street Journal about, oh, it's behind schedule, they're not going to get it up and running. Our belief is sure there will be glitches, sure there will be headlines about, some county in Indiana where people didn't get enrolled, but at the macro level, you're going to get the lives. You're going to get the newly enrolled in the exchanges, and most states are eventually going to expand too. In the first round, sure there will be states who don't do the Medicaid expansion, but we very much believe that 2 to 4 years down the road, other than a few outliers like in Texas, we're going to have pretty much expansion everywhere. It might take an electoral cycle in a place like a Pennsylvania or Wisconsin. You need maybe a Democrat governor to push it over the edge, but eventually the vast majority of states will get in. And it's good for healthcare. Hospitals, labs, pharma, all get more consumption and better payer mix. Even an entity like Medicare Advantage, which took only cuts and by definition gets no benefit from the coverage expansion, going great. Just the other day, 10% year-over-year growth in Medicare Advantage, even with the cuts from the ACA. So President Obama got reelected, and it's great for the healthcare sector.
So just to help us get grounded, John, just share with us the difference between the state exchange, the federal exchange, the hybrid model, and a private exchange also, please.
Sure. The federally facilitated exchanges are in some ways, I think, almost a good thing for the administration, in that it's probably one of the simplest ways to do it, right? So they essentially have contracted out to a single vendor to do these federally facilitated exchanges. They've simplified them a little bit, right? They made the shop exchange slightly less complex in the sense that as originally envisioned, if you were an employee, you would go to it and you'd be able to pick different plans. They've made it slightly simpler in the sense that you're basically your employer picks one and you just get that. So actually, it's the way it works in Marwood. So not exactly a big loss there. The states that really embraced it, the Massachusettses and the Californias and the New Yorks and the Illinois that have gone forward with their own exchanges are actually doing pretty well on the timeline. The California exchange is probably one of the most interesting ones. They've taken that active purchaser model that most other states aren't doing, and the federal exchange is not doing, in which they've actually tried to get some price out of the plans. Pretty much everywhere other than California, in Massachusetts, there's really no bargaining, there's no aggregation of volume to try to drive down costs for the plans. It's really a display mechanism. Again, with the exception of California, so I think it's worth watching California to see if they somehow do drive some savings there, and then maybe that spreads to other states, which could be potentially negative for plans. And then the place I do think there is some operational danger is the hybrids, the places where, like a Utah, I think there's about 8 or 9 states that are in this bucket, where they've done an exchange, they've sort of done it, but they haven't done it sufficient to meet the requirements of the ACA. And so now you have the federal government coming in to kind of try to wrap around it, plus it up, make it meet the requirements of the ACA. And that just seems to me on just sort of a basic human error level. You have a state bureaucracy, you have a federal bureaucracy, they're kind of working on something that doesn't quite meet the requirements of the law. Those could be the places where, again, you see some more of these glitches. But again, these will be glitches. We don't see delay. And even to the extent there's problems, let's just say premiums were destabilized or something, the administration will try to address that via regulation. I really don't see President Obama ever going sort of hat in hand to the House Republicans and saying, oh goodness, the exchanges aren't working, please help us fix them. And one, they would refuse, and it would take so long to do it that it probably wouldn't be sufficient. So if there is a problem, I do think it'll be interim final regs. And do they have the legal authority to do that? Maybe, maybe not, but they'll just wait for somebody to sue them. So maybe some of the lawyers in the audience here could help out on that one. And the last one, private exchange, is actually a little bit of news this morning, and we just were writing a note about this recently. eHealth and Hewitt partnered just today to have eHealth be involved with Hewitt clients who have employees who don't qualify for their employer-sponsored insurance. I'm not exactly sure how big of a bucket that is. It's like part-time workers at Fortune 500 companies. But anyway, they did partner to have eHealth get in there and help those individuals utilize the private exchange that Hewitt's running. And another part of Marwood that doesn't involve me as much does do a lot of work with TPAs and self-insured employers, and so we've definitely seen a lot of the talk about these private exchanges. A couple of big private equity firms have almost created their own in-house benefit management company, kind of an exchange-like function. Seems like a good idea to us. I think it's sort of maybe, as with many things, oversold a little bit by some that it's going to be some great breakthrough in savings and healthcare, but it's an interesting development.
Okay, great. Thank you, John. Eric, healthcare payers, insurers have always sold through brokers. Right? So in this HIE world, they're going to have to sell directly to consumers now. Are they ready? Are they really prepared to do that?
Yeah, it's very fascinating to work with some of the insurers as they're moving into the exchanges. I mean, first and foremost, whether or not they choose to participate in a lot of these states, we're seeing some big insurers, Aetna and Cigna, for example, saying, I'm not going to participate in certain states. We're also seeing a lot of them start to say, I'm not entirely sure how I'm going to reach out to the consumers. And so obviously the administration has come out with the idea of the navigator, someone out there to help people, especially a lot of the uninsured folks, find their ways into plans. The insurers themselves are trying to find ways that they can do this without violating some of the rules. What's really fascinating to watch, and it kind of goes along with what John was just talking about the difference between the types of exchanges as well, is the efforts that you're going to see at the state level to convince or to find the people who are out there who need insurance. So for example, a lot of the work that I do is directly with hospitals, and one of the things we've been talking to them about is you as a hospital, you as a provider want the exchange to cover your uninsured. You want it to cover the folks who've been coming in and getting free care. So one of the things you can do is use the same people that are doing a lot of the Medicaid assignment. As most of you probably know, when a person shows up to a hospital, they will immediately figure out if that person qualifies for Medicaid today. If they are, they will go sign them up. Well, you're tracking that information. You're finding out what the income and what the eligibility criteria will be. You can reach back out to those people over the next couple of months if they did not qualify for Medicaid. And you can say, hey, by the way, don't forget, there's this new thing for the uninsured. It's really quite amazing today, the lack of awareness that people have. Personal story, I've been working with a realtor recently, and her daughter is uninsured, and she was just asking me, she's like, I'm really concerned about my daughter in a couple of years because she won't qualify for my coverage anymore. And I just looked at her and said, do you know about the exchanges? And she said, no, what are those? And I just kind of stopped and went, this is someone who absolutely should know about the exchanges, someone who should know about the subsidies that are coming, that we're only 6 months away from, and she did not know about this. So there's a lot of lack of awareness out there still, especially amongst the population that will benefit. We're seeing the hospitals start to gear up for that. They're starting to say, I'm going to find people to get enrolled. Obviously, the insurers are sitting there going, well, that's not necessarily the population that I want insured right away because it's the highest risk population. So the insurers are trying to counteract that. I think the final variable that's fun to watch is, again, this back to, is it a federally facilitated exchange? Is it a state exchange? And how much effort will there be within the state itself to raise awareness? Watch an Illinois versus a Texas, for example, where there's a lot of effort. There will be a lot of effort here in Illinois, where the state has a lot of incentives to get people enrolled in the exchange, versus somewhere like a Texas, where the state has very much said, we're not interested in participating in this Obamacare thing. Interestingly, it walks along a lot of the same lines as the Medicaid expansions. You get a lot of the states, such as a Texas, the 25 that have said, we're not doing a Medicaid expansion. Those are a lot of the same states that have said, we're also not running our own exchange. So the uptake in insurance over the next couple of years, especially in the exchange, will be really, really variable depending on the state that you're in, depending on the efforts that are done to engage the consumers. I think the insurers themselves are one of the smallest roles. They're going to struggle to figure out how to get out to that population that's never engaged before, especially without the brokers. But you've got a lot of other constituents who are going to be trying to get the most high-risk people enrolled in these plans right away.
Thank you, Eric. I've got a question for both of you, and then we're going to open up here to the floor. So from an investment perspective, then, what type of healthcare companies do you think would do well under the ACA and the HIE? John, start with the first interpreter.
Yeah, pretty much all of them. I mean, you have to almost think in the reverse order, I think, about, what are healthcare companies that face some risk going forward. And some of that is still from the implementation of the ACA. For example, home health. Not a huge amount of benefit from the coverage expansion. Maybe you get a little bit of Medicaid coverage. Again, home health, Medicaid-focused agency versus a Medicare-focused agency, probably radically different businesses. But we are waiting for the first year of 4 years of implementing the rebasing that was mandated by the ACA. So we're probably looking at 4 consecutive years of negative updates for the home health payment system. They could be down -2 or 3% year over year for 4 years. And these are real cuts, right? These aren't Washington cuts where it's just a reduction in the rate of increase. These are actual aggregate, negative percentages. So I think that's an area to watch. Now, oddly enough, from our world of Marwood, we say, well, yeah, there's all this, reimbursement turbulence, but that's an opportunity. So it depends on your risk appetite, right? If you want to go into a place that's got turbulence, and it can be SNFs or home health, maybe you can find value. We're also waiting for the dialysis rule to come out this summer, but beyond that rule, where there was going to be a cut as well, that's kind of maybe at the other end of the spectrum, very stable. Health IT, very stable, indirect reimbursement. Medicare Advantage took big cuts in the ACA, doesn't benefit by definition, right? They're already inside the Medicare program, but it's doing fantastic. And one thing that we have been really starting to track a little bit is with the growth of Medicare Advantage, states expanding Medicaid managed care all over the place, including to long-term care populations, and the dual eligible demo. The payer mix that providers could be facing all of a sudden as a result of the ACA and some other trends is even the Medicare part of it could be 30, 40, some parts of the country 50% managed care. So the CBO projection for MA right now is 30% of beneficiaries will be in it by the end of the decade. Plus the duals could get you to 35%. CBO is probably undershooting. And that includes areas of the country where it's 0. So I think an interesting trend coming out of the ACA for the provider side is just facing managed care. Everywhere they turn, it's always managed care.
Eric?
Yeah, I think one of the big trends that we're watching that we think is really the opportunity coming up here is the shifting of risk that's going on from payers onto providers. And it kind of mirrors in with what John was talking about. Managed care is covering more and more, and they will be covering more and more. But one of the things they're trying to do is offload some of that utilization risk. We're trying to get out of a fee-for-service environment. Some states, Vermont, for example, within a couple of years, fully intends to be almost completely outside of the fee-for-service environment. And what that means is, as a provider, you have to be able to manage that risk. So in some ways, it's a return to the 90s. It's a return to the capitation models, to the PHO models of the 90s, with the one big difference this time that we all think is going to be hugely different is the ability to better manage that risk as a provider. If I think back to the 90s and what was really going on, and yes, I am old enough that I do remember this, a lot of the providers took on that utilization risk but didn't understand how to manage it necessarily. They just looked at a low trend, a low growth rate, and said, oh, I can handle this for $1.50 PMPM. Well, then all of a sudden we got a little bit of increased utilization that was uncontrolled, and we had a lot of folks kind of either go out of business or be able to were unable to pay kind of their downstream providers. If you look back at a lot of the physician organizations back then that were taking cap risk, that's what caused them to fail. California is probably the best example of what happened around that. We're going back to that. So we're going back to this world, and it's really interesting to go out and talk to providers. Capitation has stopped being an ugly word for a lot of them. Up until about 3 or 4 years ago, if I said the word capitation, they glared at me. Well, they've come back again, partly because utilization is down, partly because they start to say, well, I can manage that risk. A great example, I was talking to a hospital out on the West Coast, which has formed an ACO with a private payer, and they've said, we'll take risk for certain things. And one of the things they took risk for was the nursing homes. And I looked at them and said, how many nursing homes do you have so that you can manage that risk? And he said, we don't own any nursing homes. We think we can manage the risk without owning the nursing home. And I wished him the best of luck on that. But you're starting to see that shift back, and where they're starting to realize what they need help on is that utilization management, the clinical side, understanding how to better manage that workflow. And there's a lot of the quality and the IT systems that are going to play into that. So I think a lot of the opportunities over the next couple of years, and I know a lot of folks are trying to find the right platform for this, is the integration of kind of the data and the population health. How do we make sure that the patients are flowing through the system in the right way? There was a great article in one of the hospital industry trade rags about 2 months ago saying there's a need for a new person out there. There's a need for a new data analyst who can understand population health and patient flow. And I wanted to write into the author and say, yes, they all work at managed care companies right now. Just go find them. But it's really, we're seeing the hospitals, the ACO structures, the bundled structures. What's going to happen is about a year from now, they're going to wake up and go, holy cow, I don't know how to do this. Holy cow, I need somebody to come in and help me manage this workflow a little bit better. We see a lot of the same things with the Medicaid MCOs that are expanding into these new populations. It's really fascinating to talk to a traditional Medicaid managed care company when they think they can easily manage the long-term care population. If any of you have ever done work looking at or working around the long-term care population, it's a wholly different subset of people than the traditional Medicaid, which are by and large moms and kids. So that long-term care population, as we're shifting it into managed care, a lot of the managed care companies are initially saying, sure, give me $15 PMPM, I can handle it, no problem. I can guarantee you in about a year or two, half of them are going to sit there and go, I need somebody to help me come in. I need somebody to come in and help me manage this population a lot better. So what we're watching and what we're really looking for are those providers, those entities that can go into a local market, can understand how that patient flow works, can understand how to better manage that care.
Thank you, Eric. I think we've got a microphone out in the audience somewhere. Craig? Great. Craig's there with the microphone. So this is your opportunity now to fire questions at our panelists. So feel free to raise your hand. Craig will bring the microphone over to you. No one wants to be first.
There we go.
Okay, we've got a hand up here in the front.
This is my healthy program.
This is your exercise for the day.
I'm going to open my gift.
Thank you very much. Going back to the conversation you were having about exchanges, my biggest question, we've seen a lot of variation in premiums that have come out since the states so far, California and Oregon. And my question is, how do you think people, consumers, when they go on to exchange, how do you think their decision-making process is going to be? What are they looking at? Are they going to look at anything about the price? Are they going to be able to evaluate what a network looks like? How do you think those decisions can be made?
My guess is price. I think I know the intent of the exchange and the intent to some degree of the standardization of the benefit packages is to make it easier to have an informed consumer. But and this is certainly what occurred with Part D. Was it turned out that the risky, aggressive pricers gained a lot of share when the Part D benefit was rolled out. So I think you're going to see a lot of people sign up for bonds plans that are priced aggressively. That's definitely our belief in Marwood.
I think one of the fascinating things to watch is traditionally we think about coverage, we think about HMOs, we think about PPOs. A lot of us are loyal to our physicians. We want to make sure our doc, our hospitals, and our network. Well, let's think about who's getting coverage in the exchange. It's mostly people who are uninsured. It's people who don't have loyalty to a physician or a hospital. And so what we're hearing, California is a great example, is they're setting up really, really narrow networks. Some of these insurers are coming out and putting a very narrow physician panel in there and maybe a narrow hospital panel. And the initial question was, well, don't you think there's going to be backlash around that? And then you start to realize, well, no, because most of these individuals, they're going to an urgent care clinic or they're going to an ER. They don't have that loyalty today, so it really will come down to price. And again, fascinating thing about from the provider's angle, as a provider, that really puts me in a bind because normally I negotiate with the insurer and I say, well, you've got employers who want access to my physicians, to my hospital. Hill Physicians in California is a great example. They are notorious for really holding out for really great rates with all of the insurers out there, to the extent that sometimes insurers try to pull them out of network, but you go into California, you go into the Bay Area, and everybody wants Hill Physicians in their network because it's a really great system. Well, let's talk about the exchange. These are people who have not traditionally gone to Hill Physicians and may not feel the need to. And I'm not going to go complain to my HR exec because guess what? I've been uninsured. My HR exec hasn't been offering me health insurance. So it is going to come down to price, and what that means for providers is we're looking at narrow networks, we're looking at low pricing, we're looking at Medicare plus a couple percent maybe. The other really fun one to watch is we've talked to a number of providers that have contracts in their clauses in their contracts with Medicaid managed care companies, and these clauses say if you as a managed care company offer any other benefit program, we'll offer you the same rates that we're currently giving you for the Medicaid. Well, look in California, some of the guys who are expanding are the Medicaid MCOs, and they're trying to use these clauses with these hospitals and saying, guess what, you're giving me Medicaid rates in the exchange. So I know I've talked to a number of hospitals who have freaked out and run back to their contracts and said, let's make sure our contracts don't actually say that. But it's a very fascinating dynamic. Again, it also goes back to who's going to enroll, how as a provider do you make sure that those people are at least have some sort of coverage, but of course then if I'm not in the network, it hasn't really done me that much good anyway.
Sorry. Okay, another question? Great.
Thank you. I have a couple questions for you. So the first one is for John. When we talk about the business model and the econ system within healthcare, one of the discussions I've been hearing lately, more with larger companies that are publicly traded, that are call it north of $5 billion in revenue behind closed doors, is as the exchanges go into effect, if the cost of healthcare keeps going up, and if they're not self-insured, right, so they're smaller within the publicly traded companies, there are actually, some folks are considering maybe at some point we drop our healthcare benefit and just give people some type of payment and let them go to the exchanges. What's the thought process as far as that kind of escalating? Once one does it, and then another one does it, and now we'll start?
Yeah, a couple of thoughts there. But CBO does capture a little bit of the so-called dropping and churning, and they show a little bit of employer going down. I've never been a big believer in the catastrophic dropping scenario. scenarios. And I originally went to the Hill. I went to the Hill as a tax person. And so I think what's often forgotten about the ACA is for the vast majority of Americans, right? The 55%, 160 million people who have employer-sponsored insurance now, and you're making above median income, which is most of those people, you still have the exact same tax incentives to want non-cash compensation as you did before the law, right? If your marginal tax rate is sufficiently high to make you and your employer come together and decide that they're going to compensate you as something that's not taxed, which in our system happens to be healthcare, then great, you both win. You're essentially offloading that tax wedge onto the uninsured people. I mean, talk about a double whammy. Now, for sure, there is a profile of company that provided insurance prior to the ACA that may now sort of rethink that calculus and decide it makes sense for both sides of the deal, right? Because there's still a competitive labor market. This is sort of a microeconomic analysis of what to do, and both parties need to want to do it. You have your marginal tax rate. Now, these are people that are like just below median income, so it's not that high, and it was maybe borderline before to give them insurance. It's a smaller company, so that the fixed cost or benefit is hard to distribute. And now the subsidy comes in. So you have to have this interaction between the subsidy, marginal tax rates, the size of the company. And yes, there will be somebody in that sort of just below median income, kind of medium-sized company that now decides we're going to drop. Now you're going to have to pay more cash compensation, right? And you have to make up for their higher taxes. And you'll have to pay the penalty, the employer penalty. And that'll happen. I think also what's forgotten to some degree, at least in terms of compliance for the people that are going to be coming in through the exchanges, is you're going to get, people want the money. They're giving you free stuff. So it's not just all about the individual penalty, the individual mandate or the penalty, right? I mean, for most of the people going in, and there are a few million people that will be coming into the exchanges and don't get a subsidy, but for the vast majority of them, they're showing up to get something. And I think that's a very powerful attractor of participation. But yeah, there'll be a little bit of churning and dumping, but for the vast majority of people, there's really not much change. Now, the Cadillac tax does hit out in like the early 2020s. You'll start to get some pressure on actuarial values of plans, but even then, that should skinny down the plan. It's not cost dumping.
And one more question. As we move into 2014, and people begin to implement the exchanges more, assuming that happens, assuming healthcare continues to go well, what happens to the distribution model for healthcare insurance? How does that change? You talked about it a little bit at the beginning here, but I'd like to hear a little bit more detail from both of you as far as call it insurers' use of brokers in order to increase distribution and sales of their plans. How's that going to change over time, do you guys think?
Well, I think just by definition, the existence of the exchanges changes the broker's world, right? There's now, to a certain degree, a government-sponsored entity that, again, in theory, an insurer can capture a life for free through that. Now, you've seen them, they're going to have to try to adapt. California and New York and Massachusetts have tried to be sort of, kind to the brokers because they want to have them help drive enrollment. So some of the state-based exchanges could be try to preserve a role for the brokers. The federally facilitated ones are allowing the web brokers to participate. Some states haven't done that, California and New York. I think it's a challenge for brokers, but I don't think that it necessarily has to be the end of that role. It's just going to be a different role, and maybe they have to figure out a way to provide some added benefit, consulting type services, and not just be kind of the raw deal cutter, find people, broker the price, deliver the lives. They have to get into a little bit more of a value add in their business.
I mean, as we watch it, again, I think it goes back to there's a growing role now for providers to try to engage and get people into the system in the way that a broker may have used to. Now that divorces it greatly from the insurers themselves. The insurers obviously don't want it to be the providers who are playing that role. They want it to be the broker that they have a little bit more control over. I think the insurers themselves are really struggling to figure out, okay, there's the new website, there's the Expedia for health insurance, but how do I make sure that my benefit, my program, my design is gaining the traction that it can be? It's interesting to watch. I agree with John. I think in some places there will be a role for a broker. I think in a lot of places the brokers are struggling to figure out what their role exactly is going to be. And I think there's also a big struggle for a lot of the folks that we're really targeting here. It's 32 million uninsured total, about half of that's trying to go into the exchange. How do you find those people? How do you reach them? That's not a community that normally goes to brokers. That's full disclosure. I was uninsured for 5 years, many years ago, before I went to work on Wall Street when I finally got insurance. But as an uninsured mid-20-year-old, I knew there was health insurance out there. I actually lived in New York at the time, and I had looked at the HIP plan on it. It cost more per month than I was paying in rent, so I kind of said no. But I didn't know my other options. I didn't know what else was available for me. Now, if there'd been a website, maybe I would have gone and looked at it, but even there I would have kind of struggled to figure out, okay, is this a good plan? Is this a bad plan? I think the other piece that we forget sometimes is a lot of folks, I agree with John, will go into that silver plan because that will be the one that's subsidized, that will be the one that has a decent premium attached to it, but the cost sharing that we're looking at for a lot of these silver plans are pretty amazing. If you look at Vermont, for example, the benefit structure, it's about a 20 to 30% copay for inpatient hospital stays. For specialty medications in Vermont, it's a 60% co-insurance. I mean, think about that. If you're taking a high-cost drug and you're in the exchange, you're paying 60% of the cost. It's kind of like, what is there really a point here? Because a lot of times those same folks, if they had to take a specialty medication, they were probably on a pharmaceutical assistance program, or they were going through some kind of low-income copay thing. So I think it'll be fascinating to watch over the next couple of years as people do engage in the system and then suddenly realize, wow, this thing isn't nearly as great as I thought it was going to be. But then it's all about relative to what and how often do you use the system. Again, as a late 20-year-old uninsured, I probably would have enrolled, but I wouldn't have used, I still don't use the healthcare system, but I wouldn't have been worried about it because I'm not engaged. But if I have the need to engage and I suddenly sit there and go, what's the point of this? Why am I still paying $2,000 a year if I'm still going to pay everything out of pocket? It'll be interesting to watch over the course of a couple of years.
We have a question in the back, two in the back.
Yeah, I'm just wondering what your thoughts are on the increasing transparency with all of these various pricing for procedures and physician services, and also the transparency now in the quality. There's so many health grades and other things coming out. How is that affecting the payers and the providers and their leverage against each other?
I think it's a nice thing, but it's very, very early in the world of having, significant impacts. And even what's put out as billed is transparent. There's a need to make some use of it. It's one thing to dump a lot of data out there from CMS. I think it's going to take a while for it to permeate through the system in a way that really changes things. I mean, the government programs are just at the little tiniest tip of the iceberg of trying to pay for value, right? Hospital readmissions just barely starting. A few quality measures, a lot of times, which are just reported. They're not even really outcome-based in some of these instances, or in pretty much all the instances. So, nice developments, very, very slow developments, I think is our view on that.
Actually really loved it when the inpatient file came out from CMS because there was a lot of fanfare around it. I was on the phone that day talking to a reporter from the Wall Street Journal who was not that happy because they weren't one of the news organizations that the data was released early to. If you noticed, the day it came out, there were 3 organizations that published, and they got the data early, let's just say that. But the Journal we were talking to them on the phone, I was on the phone with them, and they were asking me, why should I care about this? And I kind of laughed, and I said, well, inpatient charges aren't the most relevant thing in the world, and at the DRG level, as CMS released them, have even less relevance. And the reporter said to me, yeah, we took a look and we looked at kind of the average charge by hospital and laid it up next to the average length of stay, and it's amazing how much they correlated. If you think about charges, and I do a lot of my work, one of the primary things I do is actually in our data analytics practice at Avalere, so I spend a lot of time looking at a lot of Medicare data that's out there. Charges are differential by day. If you have a patient who stays 2 days in the hospital, you charge for 2 days in the bed. If they stay for 10 days in an ICU, you charge for 10 days in an ICU. So the longer a patient stays, the higher their charge is going to be. So if I look at the average charge by DRG or average charge by hospital, and I don't control for the length of stay, it's kind of meaningless output, which unfortunately was where a lot of us ended up with that inpatient data set. Outpatient's a very different story because at the outpatient level, it's a much narrower definition, and the outpatient was starting to be a little revealing because we did start to see some true variation amongst different codes. What's unclear is how private payers will react to that. So charges are still somewhat a meaningless item because some payers are paying a percentage charge, but we don't know different hospitals and how they're paying. We do know on the outpatient side a lot of payers are still on the percentage charge. So it's kind of, I agree, it's nice to start to see this to happen, but it's also, just putting out data without also putting out some sort of meaning behind it is a little bit, like we're just throwing out data for the sake of throwing out data.
And in most instances, Congress would have to legislate tying payment to any of these things. So it's a lot of things.
So we've talked a lot about infusion of cash. There's half the money that's going in are new dollars. Do you think that will actually improve health care, defined as delivery, efficiency, and outcome?
Yeah, I think in defense of the ACA, there's sort of maybe three different things you can do. You can expand coverage, you can save money, and you can improve outcomes, none of which are necessarily linked. The ACA definitely expanded coverage, which is a nice thing. I think everyone would like people to be able to consume more health care and have any number of things in their lives that are better. What it probably didn't do is saving money.